Every month, brilliant, highly experienced doctors fail the OET Speaking subtest. They don't fail because they have poor medical knowledge. They don't fail because they have bad grammar. They fail because they fundamentally misunderstand what the examiner is actually scoring. Most international medical graduates believe the OET is an English test. It is not. It is a clinical control simulation based on the Calgary-Cambridge framework. The assessors are using a highly specific scorecard, criteria C1 through C5. But what you think those criteria mean and how the examiner actually applies them to penalize you are two completely different things. Today, I am going to open up the hidden scorecard. I'm going to walk you through all 5 clinical communication criteria, expose the number 1 subconscious mistake doctors make in each one, and show you exactly where you are leaking marks. By the end of this video, you will stop guessing what the examiners want, and you will know exactly how to secure your grade B+. Let's get started. Let's start with Criterion C1, relationship building. What most doctors think this means is being endlessly polite, smiling, and letting the patient talk as much as they want. Here is how the examiner actually scores it. They are looking for clinical leadership. The number 1 subconscious mistake doctors make here happens in the first 60 seconds. I call it identity drift. Because you want to be polite, you treat the opening like a social visit. You read the role-play card like a checklist, asking the patient to re-verify details that are already printed in front of you. You ask, "Are you the mother?" or "Have you been waiting long?" When you do this, you surrender your authority and bleed precious time. To clear C1, you must execute a passive opening pivot. You must validate the patient immediately and lock in the agenda. Are you bleeding time in the first minute with identity drift? We are going to find out at the end of this video. Next is Criterion C2, incorporating the patient's perspective. What doctors think this means is waiting until the very end of the consultation and asking, "How do you feel about this treatment?" Here is the hidden penalty. If you wait until the end, you have already failed C2. The fatal mistake here is the physical symptom trap. Real hospital wards train you to ask about physical pain, but the OET requires you to elicit the patient's hidden fears early in the consultation. If a patient comes in with a headache and you only ask about the severity of the pain, you miss the fact that they are terrified it might be a brain tumor. You must prompt explicitly for underlying worries in stage 1. If you don't use a phrase like, "Is there anything specific worrying you about this today?" you miss the hidden fear, and your C2 marks flatline. Let's move to Criterion C3, providing structure. What doctors think this means is simply moving down the bullet points on their role-play card from top to bottom. What the examiner is actually grading is your ability to signpost stage pivots. The biggest mistake here is the unsignposted pivot. Imagine driving a car and suddenly turning the steering wheel without using your indicator. That is what it feels like to a patient when you jump from taking their medical history straight into a physical examination without warning them. It causes whiplash. It causes resistance. To secure your C3 marks, you must use a structural bridge. You must declare the next stage and seek consent. Now that we've covered your history, I'd like to examine your abdomen. Is it all right if we proceed with that? If you are just reading off the card without signposting, your structure is collapsing. Criterion C4, information gathering. This is where the defensive medicine trap destroys your score. You think information gathering means acting like a cautious doctor on a real ward, asking 20 open-ended diagnostic questions to rule out every possible disease. In a 5-minute OET simulation, over-questioning leaves you with 0 time for management. But there is a second, invisible trap here: passive silence. While the patient is speaking, you sit in dead silence, waiting for your turn to talk. In a spoken exam, silence sounds like disconnection. To clear C4, you must use the vocal anchor technique. You must drop micro-verbal back channels. I see. Right. Every 10 to 15 seconds. Active listening requires active signaling. If your audio track is dead silent while they speak, your C4 score drops. Finally, Criterion C5, information giving. What doctors think this means is delivering a flawless, comprehensive medical explanation of the diagnosis and treatment. What the examiner actually sees is the dictator reflex. When doctors realize they only have 90 seconds left on the clock, panic sets in. You stop consulting and you start dictating. You broadcast a dense wall of medical facts without pausing. You tell the patient what to do instead of partnering with them. C5 requires the 3-chunk rule. You must explain one single clinical point, pause immediately, and actively check understanding by asking, "Does that make sense so far?" You cannot build the next step until they agree. If you string 3 management steps together without an active check, you are dumping information, not giving it. Knowing these 5 criteria is only half the battle. Under exam conditions, when the adrenaline spikes, your internal clock will distort. 5 minutes will feel like 60 seconds. Most candidates suffer from these subconscious structural liabilities without even realizing they are doing it. Are you bleeding time in C1 with identity drift? Are you losing marks in C4 through passive silence? Or are you crashing at the end of the exam because of the dictator reflex? Before you spend hundreds of dollars booking your next OET exam, you need to calculate your exact risk of a structural collapse. I have built a free 60-second diagnostic tool for you. It is called the Timeline Integrity Audit. Click the link in the description right now. Read through the specific clinical scenarios, check the boxes for the structural habits you currently experience during your practice sessions, and the matrix will instantly calculate your exact risk of test day failure. Stop guessing what the examiners want. Stop falling into the hidden traps of the C1 to C5 scorecard. Click the link below, take the audit, and find out if your clinical framework is actually safe.